Do you know about the phone cells? Are they important for the stroke?
Foam
cells.
Foam cells in the endothelium.
Yes.
I couldn't, no, I was more into the inflammation.
Oh, okay.
That Dr. Moncada mentioned. No, they are well known because of the lipids, but, and they are part of the plaque. And that could be, when people do ultrasound in plaques, they say is the echogenicity of the plaque depends on how much foam cells and how much lipids they have. It could have a relation to the vulnerability of the plaque, but not much more than that.
Okay, so Marcelo.
Someone, because and a very simple question. The oil of olive oil is good or not for because here in Italy our grape producers are very high quality, and so we need to know something.
Actually, that is the most complicated question somebody can ask, not simple question, because nutrigenomics is an ongoing field, and even though the simple question is, of course, look on Google, and it says that the best diet is the Mediterranean diet, but I think the most commercial topic out there is nutrition, and you have 1,000 books, and I can tell you who is paying every documentary in Netflix, depending who pays what the documentary will tell you about food. But Mediterranean diet is a good summary, and it is legumes, vegetables, fruits, dry fruits, and olive oil with fish. That would be the best. And olive oil, of course, monounsaturated fats are anti-atherogenic.
I just wanted to ask if the small vessel disease is different, is a different entity, is a different pathophysiological entity, and what is the percentage of strokes that could be classified as due to small vessel disease?
Definitely a different entity, not known why, but small vessel disease is lipohyalinosis that progresses and occludes that little artery. But in some other patients, the same process dilates the artery, forms the so-called Charcot-Bouchard aneurysm, ruptures, and causes a hemorrhage. So the same process goes to a hemorrhage or to an infarction. Why? Not known. And that's the clear one. But then you have the CADASIL-like. We see patients every day from 60 years above where we see the MRI and they have white matter disease. That is small vessel disease, which is associated with cognitive decline, and many of those patients don't have symptoms. And if you do mutations, they do have mutations for vascular disease, even CADASIL mutations, right, but they don't have the manifestation. So white matter disease, small vessel disease, is something that has to be studied.
Okay.
So what are the indications to use statins? When do you use them? Can you use them as preventive, or how high the cholesterol you have to start using statins?
That's another excellent question, because it should be so obvious. The guidelines from cholesterol from 2013 said we have to make a score on you, and if your score is 7.5% risk of vascular disease or more, then you should take statins. Blindly? Would I treat you for hypertension if I don't measure your blood pressure? That's what we're doing with statins. We are treating people without measuring what happens. So David Spence from Canada invented this test in which he measures the plaque load, how much plaque you have in your arteries. We are treating arteries. We are not treating LDL in the blood. We don't care about how much cholesterol you have in your blood, quote. We measure how much plaque, how much cholesterol you have in your artery, and then we decide if a person needs treatment or not, and maybe we treat a 20-year-old and not treat a 70-year-old, depending on how much plaque they have, because that reflects the risk you have. So this is a new method, not widely used, promoted by Fuster. The first one that we did in Latin America, we are close to David Spence, and this is the only objective way of deciding when to use statins and how much to use, but they are widely underused. People who have had a vascular event, a stent, surgery, a TIA, whatever, they should be on the maximal dosage of statins, and their LDL levels should be below 70.
But this measure of plaque is not, you're not actually measuring the plaque, it's just risk factors that you're estimating the plaque or not?
No, we measure the plaque. It's a simple Doppler machine, but we have a software that measures in square millimeters or cubic millimeters, volume is even better, but in volume or in surface area, we take both carotids from the mandible to the clavicle, and we measure every single little plaque, 1 millimeter, 3, 5, the software adds up everything, and grossly speaking, up to 15 square millimeters is a baseline risk. We don't say low, we never say low. It's a baseline risk. From 15 square millimeters to 50, then you're in little trouble. More than 50 square millimeters, like the case I showed, you are in deep trouble. That's a high risk of stroke. That is like 20% in 5 years.
So I'm going to go to your consultation when I get back.
Okay.
No? There. So what's the incidence of problems related with long QT and how you treat them? Is there any treatment for?
It's less than 1%, but it's very difficult to know. The easy way is if somebody died in that family below the age 50, that's a very good reason. There is criteria in the UK and other countries. They have criteria on who to check. I imagine a future where every person will be checked for that, even though it's a low proportion. It manifests itself with sudden death for the first time in many patients. If you discover them, you can use a defibrillator. You advise against exercise, unfortunately, and defibrillators, and sometimes drugs, some drugs for arrhythmia. It causes torsion de pont, and then ventricular fibrillation and death.
But do you need to identify what kind of channel is being affected before you treat the person, or how you do it with genomics in that regard?
No, any of the mutations for long QT, short QT, Brugada, they put you at very high risk of sudden death, not a specific one. But again, let's be careful. You saw that the penetrance of genes is not well known. So even if you find the mutation, we are not sure who is going to have it.
Okay.
Yeah, coming back to statins, I saw in the slide that it's advised to use statins in ApoE4 individuals to prevent myocardial infarction. Is that correct? E4, the apolipoprotein.
No,
E4.
I understand. No,
Is that correct? And is there any parallel study on what effect has on Alzheimer?
Very good questions. When you do sophisticated vascular prevention, you would like to do that. This should be done in everyone at a very young age, because we also know now trauma, American football. If you have ApoE4 and you get hit on your head, the chances of getting dementia or psychiatric disorders at an early age, we have learned from concussion, there's a movie, book, etc. And the same for this. You will be more aggressive in people with ApoE4. When you add all the other risk factors, maybe you will treat them more aggressively if you know they have ApoE4. Yes, and of course, there is a link, very strong link. The Pittsburgh University has worked a lot with this, between vascular disease and Alzheimer's. Vascular disease is not the cause of Alzheimer's, but vascular disease is very likely to precipitate, exacerbate, and have a very strong close link to why do we see so many 90-year-old people that are cognitively well nowadays? What has been the difference over the last 20 years? Vascular prevention.
Please, I'd like your comment on the correlation between plaque and the calcium score, which is another way for you to measure, not necessarily the plaque would be the most important, actually, analysis, but the calcium score is also very important, relating the risk of coronary disease.
It is so important because it has become popular to do CAT scan, multi-slice CAT scan of your coronary arteries. You see them beautifully, and you see if they are occluded or if they have a lot of calcium. And if you have a lot of calcium, that means you have a high risk of myocardial infarction. However, the question is so important that Valentin Fuster led a study comparing calcium score with plaque measurement. And what did the study show? The bioimage study published in JACC in March 2015, that there was no difference. So with a study that is totally non-invasive, plaque measurement, totally non-invasive, and no radiation, you have the same predictive result as doing the multi-slice CT, which is a very expensive test, and the radiation you get from one multi-slice is like 100 chest x-rays. So it's quite strong to decide to do plaque load rather than calcium score, but not everybody has accepted this. There are many incentives, and multi-slice CT is done.
One last question.
Okay. Sometimes when we don't find the differences is because we are not looking at the right variable. And Monsignor brought the issue of the diet, Mediterranean diet, which is very good. But do you know of any epidemiological study where they look for the influence of the quality of meat? In the United States, the beef is sacrificed 3 months before they die because they feed the cows with corn, and corn is inflammatory. So you eat a lot of cytokines which are thermoresistant. And the same happened with poultry. So do you know of any epidemiological study where people study the possible influence of eating pro-inflammatory molecules and that will make you more susceptible to cardiovascular problems?
I don't know any studies. I don't think studies have been done, but first of all, genomic studies for vascular disease in polygenic diseases like stroke are very difficult. We can analyze up to 1 million SNPs, and for one study, and each SNP is an independent event. So how do you do with a p less than 0.05? How many high false positives you have? You need a Bonferroni correction to account for that. But in meat, you have carnitine. More than saturated fats, the problem is that meat has carnitine. Whatever cow are fed with, they have carnitine, and the microbiome transforms carnitine in trimethylamine, which is a very potent atherogenic. So the problem with meat is actually causing atherosclerosis strongly because of this transformation due to the microbiome that we have. No study that I know that has proven anything.
Okay.
Okay, so thank you very much for the nice talk.